So I think we're up for some questions. So we're taking questions from the audience.
Yes, and I'll start. And
Okay.
I want to remind those in the audience that if you do have a question, please come to the microphone since this is all being recorded.
Could we have the lights up a little bit? It's
Our
difficult to see in the back
clinicians
here.
have one interesting variable that I know a lot of physicists know about, and that is that they might stay with a particular protocol, but they might introduce having the treatments being done daily. Maybe they'll have them done every other day. Maybe they'll have a weekend break. And I've actually even seen some where there's weekly treatments. So I thought I would see what your opinions were based on your three perspectives on optimal time intervals between treatments.
Okay, I must admit, quite strong opinions on this, because I think we know the answer to this. And there are two issues involved in this. The first one that I think Brian alluded to beautifully is that you want to allow sufficient time between the fractions for the hypoxia to basically go away that you generated from the first dose. So that's the first factor that's involved. The second thing that we've got to always bear in mind is that even though we're doing stereotactic treatments, we've always got to watch for that normal tissue injury, and we know we have slow repair in normal tissues, which is going to be particularly bad if we're giving high doses per fraction. So based on that, my recommendation would be if we were giving, probably for the larger, 12 to 18 gray size doses, we leave at least 3 days between treatments. So if we're giving 3 fractions, I would recommend going Monday, Friday, Tuesday. And if you're giving 4 fractions, I'd recommend going Monday, Thursday, Monday, Thursday. But on no account, if we're giving these higher doses per fraction, should you give daily treatments. No. We have no biological rationale for that whatsoever.
Well, I think Dr. Timmerman has had some protocols that actually the patients do complete within that week.
I know, and I've talked to him about this. And I keep asking him. I keep saying, Bob, why do you do this? Because we know that for certainly for lung and for head and neck, there's really no justification for cramping up that much, because we know we're not going to get a proliferative response from the tumor inside, say, at least 3 weeks, maybe 3 to 4 weeks, certainly in well-differentiated tumors, which these early-stage cancers generally are that we're giving SBRT. So I see no justification for cramping up the treatments that short. I really don't. I wouldn't recommend that.
I'll agree, and I have to agree. The data I showed for the mouse study, that's a rapidly proliferating mouse tumor with a cells cycling every 12 hours. And you can clearly see from that tumor, maybe it was selected because it got a good hypoxic fraction. And there were large tumors. Now put a 6 to 7 millimeter tumor on the flank of a mouse and scale that tumor size up to a human to indicate how large that tumor is. You've scaled it up. And in those studies, those large tumors which were hypoxic, they were seeing a reduction in hypoxia very rapidly, and it was sticking around for 6 to 7 days. Now, clearly in a more slowly proliferating, maybe more vascular human tumor that's considerably smaller, that I would go with the 3 to 4 days that Mike suggested. Because clearly the animal data, when we accept that it's an animal tumor model, shows that you're getting 5 to 6 days of hypoxia induced, and it takes that long to come off, even after 10 gray per fraction. So 3 to 4 days I'd go with no more than that.
I also agree with what's been said. Just a caveat that if you're comparing 3 days or 4 days, all the evidence we have so far is that higher dose is better. And so if you have a choice between 3 days and 4 days, I'd say 3 days is better, higher dose with the space between them.
Question, I did see one line in Dr. Marple's slide. This is absolutely fascinating. Really appreciate all the information presented today. But the one question I have in kind of this time that we find ourselves in with this myriad of technologies to accomplish these hypofractionated or stereotactic doses, where we have variable dose rate among which equipment that you're using. And even if you look at the equipment such as Gamma Knife, where we're prescribing to a 50% isodose line, effectively across the tumor, you're going to have a dose rate that's heterogeneous. So are there any comments towards which dose rates are optimal. Should we be using the highest dose rate possible? Should we be using the lowest dose rate possible? Or is it inconsequential to the outcome of some of these biological models?
I'll let Mike go first. He's the most controversial. He's the boldest at the start.
Well, we published on that several years ago. I think it was actually a paper in medical physics, if I remember correctly. And we like to think that that was one of the driving forces for pushing up overall dose rates, that we should not be giving treatments using IMRT if we're taking 30 or 40 minutes to do it. That's not good. And, you know, for the same reason, I'm going to be a bit naughty and say that this is a potential problem with CyberKnife as well. And if I'm a patient lying on the table, and believe me, I have been, I want my treatment to be given at a decently high dose rate and completed within, say, 5 to 10 minutes. I don't want to be lying on the table for 30 or 40 minutes, because I know from a biological perspective that ain't good, because tumors rapidly repair compared with normal tissues. So you're destroying the differential that you've got in favor of the tumor.
As Mike said, there's a lot of data, as the publication referred to. In terms of, if we go the opposite way, we've got a lot of data at the moment looking at very low dose rates rather than high dose rates, and we see a different effect there. At low dose rates, we are seeing radiation is less effective at damaging those normal tissues because this repair them differently to the tumor. So I tend to agree as well. I'd get the dose in as quickly as possible, because the tumor, halfway to repair, double strand breaks, you may be talking a rapidly proliferating tumor, maybe 20, 30 minutes, 40 minutes. And if you've got a treatment of 40, 45 minutes, you're getting repair during the treatment. So I'd go with cram it in as quick as you can. Thankfully, I haven't been on the table, but I'd still go with as quick as you can.
Well, we actually have one more minute or two left, and so with no other question, then I want to throw this other one out there. So we've talked about the time intervals between treatments. We've talked about dose rate, and so another key aspect that's come up, and that's sort of the gamma knife group versus the LINAC group, and that's dose heterogeneity, the introduction of hotspots, planned hotspots within a tumor, and I'm wondering if you have some comments on that. There's lots of passion on this, that we really need to have 20, 30, et cetera, and even higher hotspots percent. Yeah.
Yeah, I don't have any direct personal experience, but just the literature certainly suggests that hotspots are good. And that, these microbeams where you're getting vascular damage but sparing the normal tissue, destroying the tumor, it's hard to ignore. So I don't know the answer, but certainly intriguing, and hotspots may be good.